Right. I'm delighted to be able to speak to you today about the evaluation that we did of the UK Yellow Card scheme and patient reporting to that scheme. Patient reporting began in October 2005. And as Peter said, our Department of Health, or our National Institute for Health Research, commissioned or put forward a call for a research project to look into detail at that. And I was privileged to be the person to lead that, along with colleagues from my university in Nottingham, and also Aberdeen, Liverpool John Moores, and the Drug Safety Research Unit. In addition, we had fantastic support from the MHRA, who provided a lot of data for this study, and support throughout, and also from a very, very good advisory group, which includes Andrew out there, who had quite a number of public involvement people on it. I'm going to be able to go through in fairly brief detail what is in fact a very, very large and multifaceted study. But what I have done is hopefully on your desks, I've printed out a copy of the executive summary. So that is available to you. And also on this particular slide, at the bottom, I've put the web address that you can go to get our full report, which comes to about 300 pages. So that's where I think you should go to if you're particularly interested in knowing more about what we have found. What I'm probably going to do in terms of time is to go through reasonably quickly the slides. I won't necessarily touch on everything, because again, I think you'll have the slides that you're able to look at afterwards if you want to. So our objectives were to evaluate the pharmacovigilance impact of patient reporting to the Yellow Card scheme, to report on patients' experiences of the scheme, to assess public awareness of being able to report, and to offer recommendations for improvements to our UK reporting system. We undertook 7 different types of studies. I won't read out of these in detail, because I'm going to briefly mention each of those as we go through. So the first thing that we did, and this is where the MHRA was so helpful, was to take all the reports from both patients and healthcare professionals that came through to the MHRA in the period 2005 to 2007, a two-year period. Just over 5,000 patient reports and 20,000 healthcare professional reports. And we did both a descriptive analysis of those and also signal generation analysis. So the descriptive analysis is helpful in the context of other large studies that have been done from the Netherlands and Denmark. More reports on women than men for both patient reports and healthcare professional reports. Patients report more suspected reactions per report, and a higher proportion of patient reports contained more than one suspect drug than those from healthcare professionals. Interestingly, and there's some debate about this beforehand, that both healthcare professionals and patient reports had similar proportions of reactions that were judged as dictionary serious, in other words, considered serious by the MHRA, and a fairly high percentage there, near almost 60%. Healthcare professional reports had a higher proportion of ADRs that caused hospitalisation, were life-threatening, or caused death. Patient reporters, and this is an important point, in our system took significantly longer to report their reactions, a median of 104 days versus 28, even in the second year that the scheme was in operation. And so that's an important thing in terms of getting the message through to patients in terms of being able to report. Patients, though, actually wrote much more, 3 times as much. Still only a median of 45 words, but still 3 times as much as healthcare professionals. And they reported a different spectrum of reactions, although there was a reasonable amount of overlap. And they also differed in the types of drug most commonly reported. And we've got all this in great detail in our report if you want to see it in more detail. In terms of the signal generation analysis, we did that on the full data set. And from that full data set, there were over 40,000 drug reaction pairs. But one of the really interesting things here was that when you looked at those drug reaction pairs, there was only a 10% overlap in terms of those that were present in both patient and healthcare professional reports. We then used a proportional reporting ratio method to generate signals of disproportionate reporting. We found that health professionals generated a higher proportion of potential signals than patients for dictionary serious drugs and black triangle drugs, in other words, drugs that are going under intensive monitoring. But similar proportions of the SDRs in both groups had not been previously listed on the summaries of product characteristics, which suggests patients were potentially adding value here by reporting new things. In the pooled reports, the inclusion of patient reports meant that there were over 500 additional signals generated that had either not been present or had not reached a signal threshold in the healthcare professional reports. But 186, or just less than 10% of health professional signals, no longer reach the signal threshold in the pooled data. So this is an important finding, I think, for regulators when looking at signal generation analysis. In terms of the qualitative analysis, we explored the nature and richness of patients' descriptions, touching on what Andrew was saying earlier, and compared those from patients and healthcare professionals. We did it on a reasonably large sample, given it was a qualitative study, and we undertook a content analysis of reports, followed by an in-depth qualitative analysis. In terms of the content analysis, patients were more likely than healthcare professionals to report symptoms. I think very importantly, much more likely to report the impact of the ADR on themselves and their lives. And also importantly, we were able to see that patients, without having been given instructions, clearly reported temporal relationships between the drug and the suspected ADR. One of the other things that came out of the analysis was reports of extreme nature of ADRs, even if they might not be things that are considered dictionary serious, very extreme reactions that they were reporting. And patients tended to be more elaborate in their description of suspected ADRs. So reports from patients illustrate detailed descriptions of symptoms and the social, emotional, and occupational impact of these. And also, as I said, the temporal relationship between drugs and suspected ADRs. One of the things I'd encourage you to do if you're interested in listening or looking at patient stories, as Andrew mentioned earlier, is our full report is absolutely packed with real-life examples that have come from our analysis, so you can see the sorts of things that patients report and the sorts of language they use. We then did, aside from the actual MHRA data, then we did a series of other things. We looked at a questionnaire survey of patients who had reported, and the MHRA kindly sent out questionnaires for us. We got a very good response rate from over 1,300 responses. And from that, we found some useful data. I won't go through all of this. Important things, nearly half the patients in our country actually found out about the yellow card scheme from community pharmacies. Over 90% found that the report was fairly easy or very easy to complete, although some did notice some difficulties they'd experienced. A third had expected some feedback from the MHRA, and 60% would have liked feedback. We then, on the basis of the questionnaire responses, then carried out semi-structured interviews with 27 patients and looked particularly at their main reasons for reporting. And these were a mixture of things in terms of highlighting issues with a feeling of not wanting anyone else to go through these sort of reaction again, a feeling of duty, and also some of them to actually find out other people who may have the same problem. We then also did a national survey of public awareness of being able to report. We surveyed over 2,000 people, and interestingly, only 8.5% of the general public in the UK were aware of being able to report. And 24% had an experience of an ADR, but less than 1% reported their side effect to the yellow card scheme. We also did some focus groups and usability testing with some patients. And in terms of the focus group, then the people we talked to clearly thought that the yellow card scheme was important, but they also felt it ought to be better advertised, not that the MHR haven't tried to advertise it very vigorously, and suggested the media putting in leaflets with dispensed medicines, and then giving information about the scheme on patient information leaflets. So these are things that came out spontaneously from this group. The other useful thing was the usability testing, getting these members of the public actually trying out with fictitious information filling in a paper report, filling in an online report. And this was very, very useful, and I'd suggest that other countries might consider this, even on a small scale like we did, because it can give some very useful feedback in terms of how people find themselves handling sort of web-based systems or even paper reporting forms. We also did a literature review, as you might expect with this sort of study, and found two major descriptive studies from the Netherlands and Denmark since the large review of patient reporting, which was done by Alice and Blenkinsop in 2006. So we had a number of recommendations coming from our report, and I'll go through these reasonably quickly. But to improve the timeliness and value of patient reporting, increase the numbers of reports from patients, improve patient experiences, we felt the following should be considered. Firstly, increasing publicity for patient reporting, providing information on patient reporting within patient information leaflet, with a particular emphasis on informing drugs that are going under intensive surveillance, and I'm aware that that's in the EU legislation. Making improvements to the design of paper-based forms and online reporting systems as well. And also considering the feedback. It must be recognise the potential burden on regulators, but even just automatic feedback that would at least explain to patients or reporters what sort of things are likely to happen to their report would be helpful. In terms of increasing the validity of future comparisons of healthcare professional and patient reports, I think it would be helpful to ensure that similar information is collected from both groups, particularly with respect to seriousness. And then we had a number of ideas for research. I think one of the important one is to investigate further the extent to which extra information from the patient reports contributes to pharmacovigilance in terms of signal generation and helping regulators to better recognise the impact of ADRs on patient lives. Something that would follow things through on a longer term basis than we've been able to do. And I think to actually be able to show that, well, we've found this particular reaction with this drug, and we can demonstrate that patient reporting has actually contributed to that information coming to light earlier, for example. I think also investigating the advantages and disadvantages of pooling patient reports with healthcare professional reports for the purpose of signal generation, given that some healthcare reports may get diluted out with patient reporting going in there. And also to look at whether increases in publicity or improvements in reporting system can increase the numbers and quality of reports. And then also we felt from some of the qualitative work exploring the value of using patient reports of ADRs for educational purposes for healthcare professionals so they can better understand the impact of ADRs on patients' lives, and for education and self-help patient purposes for patients. So in summary, we've undertaken an ambitious series of studies on patient reports to the Yellow Card scheme. I think our findings are really encouraging in terms of the contribution of patient reporting, and it's fantastic that it's coincided really with the legislation going through the EU, and I think it's very supportive of what the EU are doing here. The last point is more for the MHRA. So in terms of further information, the executive summary I've given you, and there's the website for getting the full report. And also just to let you know that we have our own international conference taking place next Friday at Friends Reading House at Euston Road, and some of you will have one of these flyers on your desk. You'd be very welcome to come along, and we're still taking bookings. Thank you.
Thanks very much indeed. Tony presented so quickly that we have some time for questions. And I have to say, I think it's certainly to my knowledge, the biggest and most thorough and comprehensive quantitative and qualitative assessment of patient reporting and compared to healthcare professional reporting that's been done. So the floor is open if people would like to ask questions to Tony, who's representing the study team. Oh, go ahead, sir.
Thank you. I'm Pascal Rauder, representing the European Specialist Nurses Organization. I was surprised at exactly what you are just saying, that there was a difference between the report done by the healthcare professionals and the report done by the patients. Because most of the healthcare professional adverse knowledge, it comes from the comments from the patient itself. I mean, it's the patient who is expressing some disagreement or things like that. So I was surprised how much does it mean that some of the patient reports done to the healthcare professionals were minimized by the healthcare professionals?
It's possible. I think what you're referring to is the fact that there was so little overlap in the drug reaction pairs. Is that right? That there was only a 10% overlap. That patients seem to be reporting different types of reactions to different types of drugs to what healthcare professionals were doing. And I think it may be that healthcare professionals perhaps have a different agenda in terms of what they consider important compared to what patients consider important. Although, as I say, we did find on the reports themselves, then the similar proportions were considered serious. And there is information from other studies that suggests that healthcare professionals, I suppose, may be particularly bound by what they think is an important reaction or what they think actually might be a reaction associated with the drug. Whereas patients, will have their own views and experience, and often you'll find it from our study, very strongly held views, very convinced that the drug has caused this reaction. So I think it will be different perspectives coming from the healthcare professionals and patients.
Actually, two questions. First, had that difference also something to do with events that were in the label or not in the label? So were there less reporting of events in the label by physicians as compared to patients? And then second, can you give a bit more information on the follow-up process on patient reports? That
on the follow-up
on patient reports, what the process is in place?
Okay. In terms of the labelling, it was interesting that, as you might expect, when we did the signal generation analysis, then healthcare professionals were more likely to presenting identifying problems associated with drugs undergoing intensive surveillance. But that's not surprising, given that patients in this study were not given that information. They do not have that information. But in terms of new things, new problems or potential problems identified, we found that actually was similar in terms of the SDRs coming from patients and healthcare professionals, in terms of the proportions of those that were actually for things that were not currently on the label. The other thing was about the follow-up. Is it the follow-up in the UK system in terms of patient? I mean, I may not be the best person to answer that, and perhaps Mick, do you want to answer it now?
On the form that the patient completes, there's two questions. One is, can we follow up for further information? And the other one is, can we contact your doctor? And we ask for the doctor's contact details. So if we consider that the report needs further information, we have an algorithm looking at completeness and seriousness, and we will follow up according to that. And so we will follow up patient reports as much as we will follow up a healthcare professional report.
Go ahead.
Hildrun Sunset, European Institute of Women's Health. I'm interested in the reporting by females, 67% you said. Now, is that, did you adjust it for that women take more medicines than men, or do women have more adverse drug reactions? Can you, is there any explanation on that?
Yeah, we had some very interesting discussion and debate with our advisory group on that. Anita Holcroft was one of the members of the advisory group, and she had sort of very strong views on this. I mean, in terms of the 67%, I mean, that's just factual in terms of it was 67% of the sample were on reports from women. So I think there are more reports on women because women tend to take more drugs, but also it's not been very strongly investigated, but it would also appear that certainly in some circumstances women may be more susceptible to adverse reactions than men.
Last question here, and then I think we're going to move on to the next speaker, I'm afraid, so go ahead, please.
Josie Drapwell, Primary Immunodeficiency Association. Did this study also include over-the-counter medicine, and if so, what was the percentage?
I can't remember the percentage, but it will be in our report. It did include it. It was relatively small percentage of the overall reports. We did look specifically at over-the-counter medicines deliberately in terms of those that had come through from patients, and there weren't any particularly startling things come out. I mean, I think we've probably looked about 20 in detail. Yeah.